So we'll make a start now. So good afternoon to you all, and welcome to this third official scientific press conference, which will focus on NAFLD and NASH at the ILC 21. I'm Phil Newsom. I'm the Secretary General of the European Association for the Study of the Liver, which is the convener of the ILC. As many of you will have seen, there's been a lot of press attention this week, especially in the UK, around obesity and its link to NAFLD. And I think this will only grow given the recent decision by the UK government to ban online and TV advertising of junk food. So without being UK centric, it'll be interesting to see how that plays out across other countries. So it's clearly positive that there's this focus on obesity and diabetes. And there was a study presented earlier this week, which touched on the passing down, if you like, of NAFLD from obese mothers to their children. And I think this type of work will hopefully get us talking about the prevention of NAFLD, because we know that, outside, notwithstanding the problems with COVID, NAFLD is the fastest growing condition, unfortunately, globally, really. So if we look at the figures on non-alcoholic fatty liver disease, it would appear that it accounts for approximately about a quarter of the population is affected by NAFLD. And it's now probably become the most prominent cause of chronic liver disease globally. And it's predicted over the next 10 to 15 years to become the leading cause of liver transplantation. And indeed, is becoming so already in many countries. It's also the fastest growing cause of liver cancer, hepatocellular cancer. So we clearly are in a race here against time to try and prevent more disease developing, so focusing on prevention, but also trying to develop new treatments to try and help patients who've already progressed to advanced fibrosis and cirrhosis. So I'm very lucky today. We've got a fantastic group of experts and colleagues. But before I introduce them, just some housekeeping. So the live press conference that you're at has been recorded and will be available on the EASL YouTube page after it's ended. The embargoes on all the studies that have been presented in this session has now been lifted. So first of all, we're going to hear brief remarks from each of our speakers. And then at the end, I'll open it up for questions from the media representatives that are attending today. And if you could please mute whilst you're sitting during the meeting. If you want to ask a question, if you could please send it via the chat box. And if you could indicate your media outlet and also who you would like to direct the question to, so we can make the most efficient use of the time. And if you want to ask a question verbally, please use the raise hand feature so we can turn on your microphone. So one final point, we want to get through lots of questions, so keep the questions brief, please. So with that, we'll kick off. Our first expert today is Annie Kardashian, who is an assistant professor of clinical medicine at the University of Southern California in the States. And she's going to set the scene today by briefly describing some really interesting work around food security and NAFLD, which she presented yesterday in the general session. Over to you, Annie.
Thank you, Dr. Newsom. So in our study, we examined the association of food insecurity with mortality in adults with NAFLD and liver fibrosis. So just briefly about food insecurity, it's defined as a limited or uncertain availability of nutritionally adequate foods or the inability to acquire foods in socially acceptable ways. This is becoming more and more important because it's a growing public health problem here in the United States, but also globally. Even before the COVID-19 pandemic, about 35 million people and 18 million households in the United States experienced some degree of food insecurity. And that number in the US is now estimated to be as high as about 50 million, just as a result of the pandemic in the last year. In other disease states, food insecurity is a well-established contributor to poor health outcomes. So this includes diabetes, obesity, cardiovascular disease, including cardiovascular-related mortality. And in recent years, it's emerged as an important social determinant associated with a greater risk of NAFLD and NAFLD-associated liver fibrosis. What's not known is how the impact of food insecurity on long-term health outcomes. So that's what we really wanted to study in our analysis. So the aim of our analysis was to determine the influence of food insecurity on mortality in adults with NAFLD and liver fibrosis. We utilize the NHANES, or the National Health and Nutrition Examination Survey, which is a large nationally representative sample of US adults from 1999 to 2014. And we measure food insecurity using a very well-validated household food security survey module that was developed by the US Department of Agriculture. And we measured NAFLD using non-invasive risk scores, including the APRI, the FIP4. I'm sorry, we used the US Fatty Liver Index to define NAFLD, and then to measure advanced fibrosis, we used the APRI, FIP4, and NAFLD fibrosis scores. So in total, we included about 4,800 adults with NAFLD and about 1,600 adults with advanced fibrosis. And in total, 28% of the NAFLD group was food insecure. And that number was significantly higher than the general non-NAFLD population, which was 18%. And 21% of the advanced fibrosis group was food insecure. And in both groups, people with food insecurity were more likely to be, as expected, more likely to suffer from poverty, have lower high school, or have less than a high school education, or be publicly insured or have no insurance. And they were also more likely to be obese, diabetic, and to be non-Hispanic white. So in the NAFLD group, in our multivariable regression, food insecurity was associated with a 46% higher risk of death, even after we controlled for sociodemographic factors, poverty, insurance status, education level, and metabolic comorbidities. And in adults with advanced fibrosis, that greater risk of death was 37%, and both of those were statistically significant, again, controlling for numerous socioeconomic factors that are available in the NHANES. So in summary, food insecurity is prevalent in the United States in adults with NAFLD and advanced fibrosis, and it is associated with a greater risk of death in this population. So this study really highlights the importance of us really focusing on upstream social determinants of health in the long-term outcomes of people with NAFLD and advanced liver fibrosis. And our future study should really focus on designing interventions to reduce food insecurity in our at-risk patients with fatty liver. Thank you.
Great, thank you very much. That was fascinating.
Thanks.
So we'll now switch to Rohit Lumba, who's Professor of Medicine, Division of Gastro at the University of California. And he's going to talk a little bit now about some early work on a new RNAi therapeutic in NASH. Over to you, Rohit.
Thank you, Phil. Great presentation, Annie. I'm delighted to be here. This poster describes preliminary results from Aerohd 1001 phase 1 2A clinical trial. This is an interim analysis that includes data from healthy volunteer cohort, as well as the first 5 patients with suspected NASH. And the study was sponsored by Aerohd Pharmaceuticals. I think this is really a pivoting point in NASH therapeutics, where we're starting to see treatment of NASH related to what we've learned from genetic underpinnings related to NASH pathogenesis. We know, based upon recent human genetic data, that a loss of function mutation in HSD17B13 provides a strong protection against liver injury across a variety of liver diseases, including alcoholic liver disease, but also non-alcoholic steatohepatitis. Now, Aerohd is a RNA interferon-based therapeutic designed to selectively target HSD17B13 mRNA in hepatocytes, and thereby reducing the expression of the protein and potentially improving downstream liver injury related to steatohepatitis. In this study, 32 healthy volunteers were randomized to 1:1 to 4 dose levels, 25 to 200 milligrams of Aerohd or placebo. And then 5 patients with suspected NASH received 100 milligrams of Aerohd on days 1, and then again at day 29. Summary of major safety is most common treatment emergent adverse event was headache. There were no Aerohd associated grade 3 or grade 4 lab abnormalities, and there were no drug-related serious or severe adverse event. In terms of pharmacodynamic response, this is really important, is mean mRNA reductions were 84% with a range of 62 to 96 that were seen with protein reductions of 83% or greater. 2 patients had protein reduction of 92% and 97%. This translated into mean ALT reductions of about 46%, with all patients showing reductions from baseline. This is again proof of concept, just the first 5 patients with NASH. In conclusion, Aerohd was well tolerated with confirmed evidence of gene target silencing based upon the protein and mRNA reduction and associated with reduction in serum ALT as well. So these data support continued development of Aerohd in patients with non-alcoholic steatohepatitis. Thank you.
Thank you very much, Rohit, and it's really exciting to see that innovation coming through. So our next speaker is Professor Arun Sanyal, based at the Virginia Commonwealth University in the States. And Arun's going to describe some work using Icosabutate, which is a novel structurally engineered fatty acid, and its role in the treatment of NASH and fibrosis. Over to you, Arun.
Yeah, thanks, Bill. It's a great pleasure for me to talk about the pre-specified 16-week interim analysis of a phase 2b trial of the molecule Icosabutate, which is produced by North Sea Pharmaceuticals for the treatment of NASH for patients with fibrosis stages 2 and 3. This is a phase 2b trial with 264 patients who are randomized 1:1:1 to receive placebo, 300 milligrams or 600 milligrams of Icosabutate. There is a pre-specified 16-week analysis for the first 90 patients, when the first 90 patients have completed this time course. And essentially, the objective of this interim analysis was to get a readout of a proof of concept, if you will, that some of the core pathways involved in the development and progression of NASH are actually being improved. Now, Icosabutate is a pharmaceutically modified fatty acid based on N3 polyunsaturated fatty acid structure, where the chemical modification prevents it from being incorporated into triglyceride particles easily in the intestine, so it gets absorbed directly into the portal vein and thus increases liver exposure. It also has an oxygen molecule in its tail, which prevents it from getting into the mitochondria and getting oxidized, so it does not use become itself a source of oxidation and is resistant to peroxidation. And finally, it shuts down the production of lipooxygenases, which are downstream of N3 polyunsaturated fatty acids. And many of these lipooxygenases are very specifically increased in NASH. And so to get this proof of concept, we looked at markers of liver injury, such as AST and ALT, and even alkaline phosphatase, and all 3 improved significantly and in a stepwise manner with this active drug. Oxidative stress decreased as evidenced by improvement in GGT, which is also significant. Systemic inflammation, as read out by CRP, also improved significantly. And for fibrosis, 2 types of markers were used. One was ProC3, which is a marker of fibrogenic drive. And these patients started with a high ProC3. The median was in the 18 to 19 range, and there was a significant improvement in ProC3. Furthermore, another fibrosis biomarker, the extended liver fibrosis or ELF test, all of the components improved with active therapy. In terms of the extrahepatic milieu, there was an improvement in insulin resistance and the overall HOMA-IR. LDL cholesterol improved to some degree with the high dose, and then triglycerides improved. And this has been shown previously as well in other cohorts. From an imaging perspective, there was a trend for improvement in corrected T1. And importantly, there was no change in MRI-PDFF. Now, this drug, remember, works on the interface of oxidative stress and downstream of inflammation, of which is inflammation, fibrosis. And so all of those downstream elements did show improvement, while the steatosis did not really change. So we're encouraged, very encouraged by these initial findings. But of course, the final proof of, will come when we actually have the histology data for the full trial at the end of 1 year. So with that, I'll stop. Thank you.
Great, thank you very much, Arun. So now come to Steve Harrison. Next, Steve is Medical Director at Pinnacle Clinical Research at the University of Texas, and he's also a visiting professor of pathology at the University of Oxford in the UK. And he's going to present some data or discuss some data around the ongoing trial with Resmedorom. Over to you, Steve.
Yeah, thanks, Phil. Great job, guys, presenting before me. So I just wanted to bring a little bit of clarity and light around the presentation that is happening today at EASL, entitled really to focus on the Maestro NAFLD-1 trial, which is one of two ongoing phase 3 trials with Resmedorom, which is an oral liver-directed thyroid hormone receptor beta agonist. It's been shown in phase 2 already to have impacts on NASH resolution as well as atherogenic lipids. So in thinking about phase 3 development, there is the registration trial. It's called the Maestro NASH trial. That's an ongoing study that's currently enrolling. But in addition, there's another phase 3 trial called the Maestro NAFLD-1 study. And the purpose of this study is really to generate additional safety data, as well as some data from a real world population using non-invasive tests, as well as looking at lipids. So to set the stage, the way this trial was designed is there's a placebo group, there's a 100 milligram dose group, an 80 milligram dose group. Those are all randomized groups. There's also an open label group, a 100 milligram open label cohort. It's a 52-week trial. What I'm going to be talking about today is that open label cohort. So the 100 milligram group all got 100 milligram of drug. Treatment is for 52 weeks. So the study is ongoing, but the purpose of today is to talk about the first 115 patients that have completed the 52-week study. So just some comments about the baseline characteristics. Mean age was 55, 71% were female. Mean BMI was 36, 41% diabetic, 64% hypertensive, 70% had dyslipidemia. So it's a very enriched cohort for metabolic syndrome. Some of those baseline characteristics using this real world cohort, we had a FibroScan mean of 7.4, PDFF 18%, MRE 2.67, ELF 9.3. And this is a cohort of people that were enrolled essentially using FibroScan. So CAP had to be greater than 280, KPA greater than 5.5, and an MRI PDFF of greater than 8%. So utilizing that enrollment criteria, we still had a FibroScan mean of 7.4. Now, another interesting tidbit here is about 12% were on a GLP-1, 13% were on SGLT2s at baseline. So what were some of the main features of the trial that we're reporting? CAP was able to drop by about 45 units. MRE and PDFF, I'm sorry, down 53% relative drop. MRE down about 0.4 or almost half a point. This is a 12% relative drop. FibroScan down about 2.8 or 26%. Getting at some of the main reasons for the trial, safety. So what we found is that the 100 milligram dose is very well tolerated. There are some early mild GI issues with loose stools that tend to abate after about 2 weeks. And that was seen in roughly 10% over the placebo. We also know that 95% of patients completed the study. None discontinued due to an adverse event. So it seems to be safe and well tolerated at this higher dose of 100 milligrams. Atherogenic lipids consistent with the phase 2 also dropped. LDL cholesterol, ApoB100, Lipo-A, and triglycerides all down significantly. So in summary, consistent with data that's been generated already, we see with the higher dose of 100 milligram in this open label cohort, a drug that's safe, appears to be well tolerated, with some drops in non-invasive tests that are consistent with overall improvement in liver cell and liver health. I would say that the study is limited in that there's no placebo arm here. This is open label. So with that, I'll stop and turn it back over to you, Phil.
That's great. Thanks very much, Steve. So lastly, we'll come to Jerome Boursier, who is head of the liver and GI department at the University Hospital Angers in France. And he's going to describe some nice work around Agile 3, which relates to FibroScan and the identification of patients with NAFLD and advanced fibrosis. Over to you, Jerome.
Many thanks, Phil. I'm really happy to be here. So yes, the purpose of the study that will be presented tomorrow is a work in collaboration with the Ecoscience Society that aim to develop a new test for the non-invasive diagnosis of advanced liver fibrosis in patients with NAFLD. So as you all know, NAFLD corresponds to excess fat in the liver. It affects 25% of the worldwide population. And some of the patients will develop inflammation. And this inflammation will induce accumulation of fibrosis in the liver and lead the patient to cirrhosis, liver-related complication, hepatocellular carcinoma, and death. And we know that those patients with advanced liver fibrosis correspond to a subset of patients at high risk of liver-related complication. So they should be identified in priority in clinical practice. And this will become even more relevant because, as we just discussed before, there will be, we hope, soon treatment available for these patients. So today we have two non-invasive tests available for this identification of patients with advanced fibrosis, so blood test and elastography devices. So blood test is very easy to understand. You make a blood sampling, you measure blood marker, and then they are combined in a formula that gives you the probability of having advanced fibrosis. And you have also the elastography devices. So it's a probe that you apply on the skin, and it measures the liver elasticity, that it is well correlated with liver fibrosis. The examination takes only a few minutes. It's painless, and you have the results immediately during the consultation. So the idea of the study was to combine both methods, the elasticity measured by FibroScan and the blood marker in a single, quite super test for the diagnosis of advanced liver fibrosis. So the test was developed in a large cohort of patients with 1,500 patients with biopsy. Biopsy was the reference. And it has been further validated in 3 different cohorts of patients, an internal validation including 700 patients with liver biopsy, a US cohort including 600 patients with NAFLD and liver biopsy, and a French cohort with more than 1,000 patients. So the results, there are 2 main results for this study. So AGILE-3, that combines the FibroScan with simple parameters around transaminases, platelets, and clinical data such as age, sex, and diabetes, so a very easy to obtain test, significantly improves the accuracy, the ability to detect advanced liver fibrosis compared to FibroScan alone or to blood test alone, and the blood test that was used here was the FIB4. So you increase the diagnostic accuracy. You're better to detect this patient. And the second point, so you have to understand how is interpret non-invasive test in clinical practice. So the AGILE-3 is a result that ranges from 0 to 1. You have a lower cutoff and a high cutoff. Below the lower cutoff, you exclude the disease. When the result is above the higher cutoff, you can affirm the disease. And when you are between the 2 cutoff, it's a gray zone where the diagnosis remains undetermined. And AGILE-3, because it is more accurate for the diagnosis of advanced fibrosis, it significantly reduces the uncertainty, the gray zone, to less than 20%, which is much less compared to FibroScan and to biology. So to summarize, this innovative combination of blood markers with FibroScan measurement in a single super test improves the diagnostic accuracy and reduce the requirement to liver biopsy because the gray zone is much lower, which is very interesting for clinical practice and identification of those patients in need for specialized management among the large population of NAFLD patients. Thank you.
Great, thank you very much, Jerome. So now I'm going to open for questions. We've got just under 20 minutes, so questions and snappy answers so we can get through a lot. Please use the chat function. Again, indicate your media outlet and who you would like to direct the question to. So let's kick off. So Anna, yours has triggered quite a lot of discussion. So there's first one here from Keith Alcorn from InfoHep, wondering, could you give some examples of the interventions you would like to see tested to reduce food insecurity in individuals with NAFLD?
Sure, yeah, so that's a great question. So, generally when I think about interventions for social determinants of health, I use the National Institute on Minority and Health minority health and health disparities. And they have a research framework that really focuses on levels of influence. So there are individual levels of influence, community, and societal, and interventions can really be focused on each of these different levels of influence. So when I think about interventions for at-risk patients with NAFLD, I think at the level of gastroenterologists and hepatologists, we should consider screening our patients with chronic liver disease for food insecurity, and then in vulnerable populations or those who sort of trigger, are being food insecure, then refer those patients to dietary counseling with special attention to their resource limitations and really focus on linking them to food assistance programs. There's also, one other thing, there's data in the community level, just in terms of community partnerships in the world of diabetes, and how partnering with food banks can help to improve diabetic control and hemoglobin A1C control. So similarly, developing programs where we would collaborate with food banks to improve diet, in patients with NAFLD.
Brilliant. And one quick follow-up question from Ingo Van Thiel from German LiverAid, asking the question, does food insecurity describe a mindset or lack of knowledge that causes malnutrition, or is it a synonym for malnutrition? So I guess a clarification of the definition.
Sure. Yes, so food insecurity really is a symptom of poverty. So it's really about not having access or resources to be able to buy food or to obtain food in ways that are socially acceptable without stealing or begging. So it really is about not having the money to be able to afford high quality or just sufficient quantities of food. So it's really more about that as opposed to food choices.
Great. So Steve, there's a couple of questions which in many respects overlap. So I wondered if I could paraphrase them for you. There's questions here from a number. We've got Virginie Baguet from APM Paris. We have Ed Sussman from MedPage Today asking the question around, and also Laird Harrison, asking the question about the rationale for an open label group, and I guess the additional information that we should be clear about from the previous phase 2.
Yeah, that's a great question. So thanks for asking that. When we did the phase 2, the dose was 60 milligram, and based on exposure, you could titrate up or down. And at the end of the day, we had very few people were on 100 milligrams of Resmedorom. So moving forward into phase 3, where we're studying 80 and 100 milligram, both in the Maestro NASH trial and in the Maestro NAFLD-1 trial, we felt like it would be important to try to get some early safety data as well as some early non-invasive testing data in an open label cohort, so we could see how these people were tolerating that drug rather than waiting for the blind to be broken. So that's the reason for that open label, is just to gather emerging safety and early efficacy data relative to that dose.
Great. And there's a sort of related question, Arun, that's come to you on that one. I just wondered if you could just add to Steve's comment, but also perhaps just a comment as to how far away are we from non-invasive markers having a regulatory handle?
That's a loaded question. I think if you're an optimist, probably 2 to 3 years away. Remember that non-invasive tests are used for a variety of reasons, from making a diagnosis, establishing prognosis, prediction of response to therapy, and then disease monitoring. So we actually, one of the problems in the field was that many studies lumped all of these different things into one study, and that didn't provide enough clarity about the utility of NITs for individual uses. So those type of studies are now ongoing, and hopefully within a couple of years, we'll have high quality data to regulatory standards out. So I'm being an ever optimist, I think in 2 to 3 years.
Great. Yes, I think that's, for the press, I think that's a kind of nice summary. I think it's, additional safety data and efficacy data non-invasively at the higher dose. So there's another question here for you, Steve, from Inga Van Thiel, asking the question about biopsy use in the phase 3 trial. I guess it's in the other arms, isn't it? It says, if no, it would be more patient friendly, but will phase 3 results without a biopsy be accepted by the regulator? in the drug approval process. So just to clarify, there obviously is a biopsy arm.
Yeah, so there's the Maestro NASH trial, which is the registration trial. You have to have a biopsy to get in. You have to have a biopsy to get out. And you know, there we're following the FDA guidance for Subpart H approval. Maestro NAFLD 1 is an additional 1,200 patients being enrolled, looking predominantly at safety. You know, one of the things the FDA has made clear in drug development for NASH is that there's a significant amount of weight put on safety and tolerability of these drugs. Now, these patients, you know, it's difficult to pigeonhole exactly what stage of disease they're in. It could be a late 3 and early 4. And also most of these people are asymptomatic, you know, so targeting safety as well as efficacy is paramount. And so that's the reason for this additional database. It's just to provide well over 2,000 patients worth of data at the time of a potential NDA.
And just to follow up on a comment from Ed Sussman, could you reflect on the sort of comparative benefits that might accrue to the liver as opposed to the broader metabolic syndrome with this agent?
Yeah, so, you know, Resmedorom really does a couple things. It's pleiotropic in nature in that it really helps burn fatty acids within the mitochondria. But within NASH patients, mitochondria are often dysfunctional and sick. And so we see upregulation of reactive oxygen species that trigger all the downstream inflammatory effects. And so another benefit of Resmedorom is increasing mitochondrial biogenesis, so replacing those sick mitochondria. So it's burning more fatty acid, it's generating healthier mitochondria, but also there's some direct effects on TGF-beta signaling and other kind of vicarious effects on inflammatory change. So pleiotropic in nature, where you're seeing fat being disposed of more appropriately, and you're seeing improvements in inflammation and potentially fibrosis through direct impact and indirect impact.
Great, thank you very much, Steve. So there's another question here from Zaina Hamza from Midpage Today. It's for Dr. Kardashian asking, what are the next steps in the research you'd like to see? And this maybe touches on a previous comment. What additional factors or interventions do you believe might improve health outcomes for this population?
Sure. So, next steps. So, one thing that we didn't really focus on in this study, but we really would like to, is looking at diet quality. We know how important diet quality is in the management of NAFLD patients. So we really want to look at the associations of diet quality with food insecurity in this population. We also would like to use more robust markers for liver fibrosis, so using FibroScan data as opposed to biomarkers or sort of non-invasive risk calculators. And then in terms of interventions, we touched a little bit already on sort of community interventions, so partnering with food banks, on the individual level, working with dietitians within your our GI and hepatology clinics, and then on sort of on the population level and policy level, it's really important that we expand supplemental nutrition assistance programs for our at-risk patients with liver disease.
Great. So welcome back, Rohit. And you're multitasking, so thank you very much. So the question for you is really interesting in terms of, not just the target, but the way you go about addressing that target. Could you, first of all, in terms of the target itself, could you put it into context in terms of, is it something that you think ultimately will have traction as a mono target, or do you think it will be something that sits alongside other sort of combinations at the same time?
I think this is a great point, Phil. I think you could potentially see it as play out as a combination, but it could also be monotherapy. Here with the Aerohd compound, we're looking at RNA interference, but there are other companies that are also developing small molecules. And I think with small molecule, probably a combo approach might be better. The other thing which would also be important is to do genetic screening potentially. I think therapy should work in most patients who have NASH stage 2 or 3 fibrosis, because they really don't have the HSD17B13 protection. But it might be even better in those who have PNPLA3 homozygosity, because there's some evidence that those who are homozygotes may potentially benefit even more with HSD17B13 protection added. But I agree, I think a combo approach, if both could be added in terms of you could silence both PNPLA3 and HSD17B13 will be good. Other possibility is that you could do some sort of a synergism. It potentially could even benefit with a low-dose FXR based upon the mechanism that we see with the HSD17B13. So I think time will tell in terms of what the actual potency is, but currently looks good, at least on proof of concept here in the 5 patients.
Yeah, no, very good. A question for you, Jerome. So I think several of us were involved in this, so we should know the answer, but this is about identifying patients with advanced fibrosis. So just a clarification, did that exclude patients with cirrhosis, or were they included within that?
The patient with cirrhosis were included. You had the whole spectrum of fibrosis stage in the study. The idea was to be as close as possible to what we observe in clinical practice. So if you exclude some patients, you're not in your clinical setting. So all the patients were included in the study, whatever the fibrosis stage. Yes.
Okay. And just in terms of many of these algorithms we develop in secondary care, could you say something around its application in other settings, primary care settings, diabetes, and what, if any, adjustments do we need to be aware of?
Yeah, that's a great question and a crucial question. So the accuracy of the test will depend on the context of use. So the context of development of this test is, as you said, a patient who underwent liver biopsy in tertiary care. So they are enriched in patients with severe disease. When you go to diabetology clinics or even more in primary care, you have less patients with advanced liver disease. The prevalence is lower. So you will be even more able to exclude advanced liver fibrosis. So you will be better, but to affirm it will be more difficult because the accuracy of the test will decrease. So there are some experiments that have been published about a sequential use of non-invasive tests in order to stratify and identify those patients who need to be referred to the liver specialist. I am thinking about the Camden and Islington pathway that use a simple test, the FIB4 as first line, and then you use a specialized test as the LF as second line. And this study clearly shows that it helps to organize the flux of patients between primary care and tertiary care. You have less patients without advanced liver fibrosis who are referred to the specialist. They don't need for that, so that's okay. And you increase the detection of patients with advanced liver fibrosis. So we need to be very careful about the context of use, but probably that the solution is a sequential use, a simple test as first line, and then specialized test.
Great. I want to get 2 more questions in before we close. So Arun, a question for you. Could you contextualize this work with the previous work that you published on PUFAs? What do you think is the driver of a difference that we might see? And secondly, I know liver biopsy is imperfect. We all know that. Could you speculate on the sort of correlation or link between the changes in the fibrosis markers and what that might look like histologically?
Well, I'll take the second one first. We're hopeful that the histology will pan out, and we won't have to really get into trying to explain away why there's a disconnect between histology and the non-invasive markers. It'd be great if it all aligned. There is certainly a possibility that they may not align. And really, then we would have to understand, based on how much of a difference there is between the histology readout and the non-invasive readouts. It will also be important to recheck the non-invasive tests at the end of study at 12 months to make sure there's durability of response. So one possibility is that, you can lose durability, but time will tell. We are hopeful that this will continue, but those are some of the reasons why there may be a disconnect, but we are hoping that we will be able to demonstrate by rigorous using best practices in histology readout, a histological readout that will mirror what we're seeing with these non-invasive tests. The first question you asked is really how this relates, Icosabutate relates to previous work with the, lipidomics of NASH. And we know there's a depletion of both N6 and N3 PUFAs in NASH. And these can lead to downstream generation of eicosanoids. And particularly, there is an increase in number of lipooxygenases, which are very pro-inflammatory. And of these, you have the 5, 8, and the 12, 15 lipooxygenases, which are the main players. There are also oxidized eicosanoids, which are very pro-inflammatory. Now, what this molecule, because of the introduction of an ethyl group and an oxygen in its tail, number one, it does not incorporate into phospholipids and does not insert into membranes. It is also very resistant to peroxidation, so it reduces. So whereas fish oil, if you give a lot of fish oil, number one, itself becomes a substrate for energy, for ATP generation. Fish oil can incorporate into phospholipids and get peroxidized and can then, artifactually actually give you increased oxidative stress. And that's maybe why many of the fish oil trials in NASH have not really panned out, is because of these mixed effects. So here what it does is it prevents that process from happening. At the same time, by binding PPAR alpha, it directs regular lipotoxic fatty acids into the mitochondria for oxidation. So fatty acid oxidation goes up, but it does not itself get oxidized, and it prevents the lipooxygenase formation. So I think mechanistically, that differentiates itself for regular fish oils.
Okay, brilliant. Thank you very much. One final question to Steve from Laird Harrison at Medscape, just asking for a bit more information about how you would present the value of the non-invasive tests, given for this particular analysis, you don't have the placebo or histological comparison.
We don't have a placebo comparison within the study itself, but we do have historical comparators, right? So again, the goal of this was predominantly safety, but where we're able to see the totality of non-invasive tests moving, it gives us, I guess, hope that ultimately this dose is going to be effective in resolving the underlying histopathologic effects of NASH that we see under the microscope. Now, again, it is one of the limitations of this open label arm that there is not a placebo comparator, but we do have data. Rohit spent a lot of his life working on this, looking at how MRE correlates with disease severity. FibroScan the same way. Jerome's done a lot of work there also. Many of us on the panel have. So, you take it for what it's worth, where we see more than one non-invasive test moving in the same direction. I didn't mention ALT, but that's also significantly moving in the right direction. Where we're seeing more and more of those moving in the right direction, it gives us hope that we will have a benefit histopathologically. But as Arun mentioned, that the proof's in the pudding. We'll see that in the Maestro NASH trial when we get to the end of 52 weeks.
Brilliant. Well, listen, thank you very much. And thank all of you for a really good session. And thank you for the others joining, the press in particular. So if you need any more information, please approach Michael Kessler from the ILC comms team, who'll be happy to arrange follow-up with any of our speakers. So thank you all and enjoy the rest of the meeting.
Thank you.
Thank you.
Bye.